afternoon, everyone. I welcome Dr. Sanjith Saseedharan, Director Critical Care at SL Raheja Hospital, Mumbai. So, sir, my first question to you is regarding the indications for use of polymyxins. So, given the increasing prevalence of carbapenem-resistant gram-negative infections, in which clinical scenario should polymyxins be considered the first-line options, and when should alternative agents be used?
So, I mean, this kind of question is a very difficult question to answer in the first place as to where I would use colistin as the primary drug per se. But however, it's all dependent on what is the pattern of infections in your hospital. Let's take empirical therapy to begin with. If it's empirical therapy, if the pattern is such that you have 20% cases of Acinetobacter or in fact more than 10%, and if it's Acinetobacter, then there is no doubt about the fact that the primary go-to drug in any infection, let it be urinary, let it be respiratory, let it be bloodstream, let it be catheter, let it be anything, it would be a polymyxin, no doubt about it, with respect to Acinetobacter. But once it comes to any of the other organisms, Enterobacteriaceae, Pseudomonas, then it's not going to be the polymyxin, it would be an alternative in the event that we have data that comes by. So one place where you would kind of, and whenever you're going to use it, it's probably going to be combination. I think we're going to get to that quickly on that too. Yeah.
And sir, when it comes to selecting between colistin and polymyxin B, my question is, what are the key differences between colistin and polymyxin B in terms of efficacy, toxicity, and pharmacokinetics? And how should we choose between them in critically ill patients?
So the difference between colistin and polymyxin B in clinical scenarios, right?
Yeah.
So colistin has unreliable pharmacokinetics.
Yes.
So polymyxin has reliable pharmacokinetics. Colistin does not achieve the steady state concentration rapidly. Polymyxin achieves the steady state concentration very rapidly. The third thing is the fact that colistin has got batch to batch variation, even generic to generic variation too. Now that variation actually puts colistin at a disadvantage, because what happens is what I'm expecting is not what happens in vivo in batch to batch. So this is seen when you actually change batches, you realize that this batch is not working as well as that batch is not working. It's seen in colistin. Okay, this is something that is seen in colistin, and we who are prescribing it, we understand this very well. Where you start colistin on a patient and you just change the batch and you find the response rate to be slightly different. So there again, colistin, that's why is very unreliable if you ask me. And the second problem that you have with colistin is the fact that you need to dose it at the upper limit of the approved dosing indications, not at the lower limits. See, if a person is coming with a normal creatinine, the upper limit is still not adequate.
Yes.
If the creatinine is, say, let me say 0.9, and you have a severe bloodstream infection, even the upper approved limits that we call in colistin is really not adequate. So you require to really go very high. And when we look at it, there's a ceiling dose to colistin. Remember, colistin is not weight based. Colistin is based on a number. You just give that number, and that's what you give. So the higher doses, when you say colistin based activity, say 360, above that you just can't do that. Above 360 you can't do that. So when you do that, you are playing with acute kidney injury. You are doing that. You are doing that, and at the same time the efficacy is going to be low. That's where polymyxin has got its edge. So you have a patient coming into the intensive care unit and you want to actually dose it in such a way that the patient takes away all the bacteria inside in the first go, the kill ratio being high. You need to give a drug that's rapid, that's reliable, and achieves steady state very quickly. And the only drug in that segment between colistin and polymyxin is polymyxin. So polymyxin will reach the levels very quickly. We can't wait for hours. We can't wait for hours. So in a patient that comes in with severe septic shock, if I'm going to wait for 7 to 8 hours, that's not the right way to do stuff. It has to achieve the steady state within an hour. And if you don't achieve that within an hour, then it's not the right way to do that. And polymyxin will do that. That's the entire difference between that. And of course, the volume of data that comes out when it comes to nephrotoxicity and neurotoxicity, I'm not saying polymyxin does not have nephrotoxicity, but the incidence of nephrotoxicity is much lower as compared to colistin per se.
Okay. So next question is regarding a very important aspect which is asked these days regarding combination therapy versus monotherapy. So what is the current evidence on the use of polymyxins as monotherapy versus combination therapy for carbapenem-resistant infections, and what combinations show the most promise?
So when you look at carbapenem resistance, no, the biggest problem that we have at this moment is we should first have rapid diagnostics. The issue comes there. So figuring out what it is, whether it is a KPC, whether it's an NDM, whether what we are dealing with respect to carbapenem resistance is first you need to figure out that, and then only we can think about the combination therapy. Now going back to what we talked. Say we give a colistin based activity of 350, say 360. So we're looking at 11, 12 million units of colistin going inside. You look at 12 million units of colistin going inside and you want to achieve a steady state. You are achieving a steady state at only 70 to 80% of the times. That means effectivity would rather be rather low, very certain. When you want to give an antibiotic in a patient who's critically ill, I want it to be 100%. But what happens over here is you're around 70% of the time. So that means to say, if I were to dose this as a monotherapy, 3 out of 10 patients would not really achieve the kind of effect that I want to achieve with colistin on its own. So in short, any time that I want to use any kind of polymyxin, the go treatment would be a combination. I mean, there would be skeptics saying that there has been studies that have talked about colistin monotherapy being effective, but those studies are not done in the Indian subcontinent where the resistance patterns are very different as compared to abroad. So in our country, if I were to give colistin, I really have to be very, very brave. And when I say if I have to give colistin as monotherapy, but if I have to give a combination therapy, I'm kind of comfortable. And the combinations that we look at are multiple. I mean, there are so many combinations, and so you would probably classify it this way: that you have colistin and you have another antibiotic that is susceptible. So in the era of a very severe septic infection, this era when we have very severe septic infections in our country, even if I have susceptible colistin and I have a susceptible meropenem, I'd probably give both of them together because of the fact that I want the synergistic action of both of them together. In the event I have a antibiotic that is not susceptible, that is, I have something that's not susceptible, I'll still give that because colistin has got that permeabilizing effect. It kind of opens up the bacteria and intracellularly. Exactly, and that's how the combination will work, even though the companion antibiotic may not be susceptible. So I mean, as a combination, and if it's and root wise, if it's say in the brain, it would be a combination for certain. Okay, of intrathecal and IV. If it's in the lung, we know very well from mouse models that the in vivo efficacy of any of the polymyxin based drugs are not good in the lower respiratory tract. We know that very clearly, that the lower respiratory tract doesn't really get into, the colistin doesn't get into that, the polymyxin doesn't get into that. So if it was something in the respiratory system, it has to be a combination of intravenous with nebulized colistin given in the right way. And when I say given in the right way, it means using a specific nebulizer, which is like a jet nebulizer, at 2 million units twice a day. So you're looking at big, large doses of colistin or polymyxin given in two different ways as combination. So combination in two different routes, combination given with two different drugs, combination. So combination therapy is the way to go. And skeptics who talk about monotherapy are really not, are those people who probably working in places where the resistance patterns are on the lower side. So we can't do that in our country for certain. Yeah.
So another question is, like you rightly said about polymyxin B and colistin not having good penetration into the lung. So what about the urinary tract system? Like,
So yeah, so it's a very interesting question. What happens in the urinary tract? So first of all, the basic of the drug is the fact that CMS is a prodrug. So since it's a prodrug, it has to first get converted, and the conversion occurs in the urinary tract. Since the conversion occurs in the urinary tract, we know that the colestins are going to really work beautifully in the urinary tract. So if I have a patient who's having a urinary tract infection and I don't have other alternatives, then I would probably give colistin. But remember this, if you were to actually, even if you were to give it in the urinary tract, you still need to dose it the right way. I mean, the dosing is a big issue here. The colistin, giving colistin is not the problem. The entire problem is the dosing, because 70% of the times you are not achieving steady state of 2 milligram per liter. You're not achieving that, and you can't do levels. What levels can you do? Because colistin gets converted to a prodrug CMS. CMS can't be actually taken. No levels can be done. So since you don't have levels, I can't say that a drug is kind of working or not. It's a problem. It's a problem. Yeah.
So in your clinical practice, have you done TDM for therapeutic drug monitoring?
So what do you do? I mean, the question is, what TDM can we do? If you want,
Is it the active form or?
you can't do it at all, because you have, this conversion occurs down there, the CMS it gets converted to, the salt is very different. And remember this, batch to batch. No, the real key to preparing colistin is the methane sulfonation that the company has to do. That methane sulfonation that's done as a bioengineered product is something that is problematic from company to company. So that's why there's a batch variation when it comes to colistin. I am not confident of using colistin anywhere outside the urinary tract. It's something that we can't do at all, I feel, because of the fact that the batch to batch varies, we don't achieve concentrations, and at the same time the doses that I need to give are humongous. If I don't give humongous doses, colistin really doesn't work.
So my next question is regarding optimizing dosing and administration of polymyxins. How can polymyxin dosing be optimized to balance efficacy and toxicity? And are there specific PKPD principles that should guide loading doses, maintenance doses, and infusion strategies?
So this is a very, very interesting and a very difficult topic also on the whole. So the PK/PD, first of all, reliability, rapidity, and the entire advantage of PK/PD lies with polymyxin. That is for certain. There is no doubt about it. Compared to polymyxin and colistin, polymyxin has got the PK/PD that is phenomenally better as compared to colistin. There is no questions about that. So in septic shock, if I have to give an antibiotic, it is going to be polymyxin. Okay, now the question is how? What do I do? How do I do this? Now let's understand which organisms have a problem here. Okay, so if you have, say, let me take Acinetobacter, Pseudomonas, Klebsiella, or the Enterobacteriaceae. Let's take it that way. So there is no data on the MICs that you have when it comes to Klebsiella, when it comes to Enterobacteriaceae. There is no data. Klebsiella, Oxytoca, Klebsiella. You name the Enterobacteriaceae, and there is really no data on MIC and breakpoints. The only MIC and breakpoints that we have with any of the polymyxins lie with Acinetobacter and with Pseudomonas, and that also they're differing breakpoints. If you see the CLSI, it's 2 and 4 for the susceptibility and the MICs, and for Pseudomonas and for UCAST it's 2 and 2. So they've got differing breakpoints also, if you think about it, when it looks at Pseudomonas Acinetobacter. So in short, I now need to understand that for Enterobacteriaceae I don't have breakpoints, because what they're going to use is ECVs, that is, epidemiological checkoffs, that's cutoff values, that's what you use. That doesn't cover that covers only wild strains, it doesn't cover the real difficult strains. So if I have to dose it for Enterobacteriaceae, or for that matter for Pseudomonas and Acinetobacter, I need to be at the upper range, absolute upper range of the approved indications. So what would be the upper range? The upper range would be somewhere at 350 milligrams of colistin based activity, which is very high. So if I say 350 milligrams, you're looking at somewhere around 12 million units as a loading dose. And if it's colistin, it needs to have that loading dose. Even if I give the loading dose, remember this, even if I give the loading dose, to achieve steady state, it may take close to 7 hours to 24 hours, because the reliability is a question here. But that's not the case when it comes to polymyxin. In polymyxin, somewhere around, say, 25,000 international units per kilogram, if I give something like that, you are achieving steady states in an hour per se. But the crux is not this. The crux is people forget that loading is not everyone talks about loading dose, but loading dose is not the only idea here. The maintenance dose is even more important. So you get the initial kill, but then you need to actually maintain that. Now, how do you maintain? That's the question. So people in forums talk about the fact that, I give a loading dose, but when do you give your maintenance dose? When? The question is when. People don't realize that the maintenance dose has to be given depending on what is your frequency of maintenance. So if you're going to put up a BD dose, say a 12-hourly dose, the next maintenance dose should be at 12 hours. So you give a loading in the morning at 7, the next dose should be at 7 p.m. The next dose will be 7 p.m. People really think that, I give my loading dose for 24 hours, I don't need to give it. And then I give it the next. And that's what happens with all the polymyxins, all the colistins, because then you start getting clinical failures and you start wondering what's really happening. The problem is that. Another very interesting part is polymyxin doesn't require any change when it comes to renal patterns. Yes. Okay, so when you have renal injuries, you don't really need to do anything. You continue the same dose. In fact, you may want to increase the dose. Okay, now this is again a problem. Now you see colistin, what happens with colistin is that there is no weight based. So you give 360 CBA, you give 360 CBA, that's the amount you want to give in a colistin based activity. But as this, polymyxin has got a weight based dose, it's units per kilogram. So in an obese individual, I am thinking in colistin, what do I do? In obese individual, I'm just thinking, should I give the same dose? Should I increase the dose? What should I do with obese individuals? Whereas I have an answer with polymyxin that says that, okay, if the kilos are high, I can reach the top max dose with units per kilogram. So that's what happens. Also, when you're redosing in maintenance hemodialysis, what we must understand is that depending on the hours of dialysis, you need to add 10%. So for example, if I have a 6-hour sled, so each hour of sled that I have, I'm losing 10% of my colistin. So if I'm using 10% of my colistin, I've lost 60% say in 6 hours. I need to add that 60% of colistin to my whole dose regime and give it after dialysis. So if you ask me if I have to dose colistin on a patient who's got SLED, it's a lot of thinking I have to do. So for example, in the morning I'm here and I have a patient who's having SLED, I was having a dialysis. So that means in the morning I want to give 2 million units. In the evening, say I've got a dialysis, so a 10% means around 3 million units, maybe 2.5 million units I want to give in the next dose. But the next dose has to be done after dialysis. So I need to set so many things right. I need to tell my nurse that you need to give this only after the dialysis, and that also right after the dialysis, not 6 or 7 hours. Because what nurses do, they would write BD, they would write 8 p.m., 8 a.m. Okay, now 8 a.m., 8 p.m. doesn't work that way. So if I have 8 a.m. and I'm having my dialysis at 6 p.m., I need to give it at 6:30 after my dialysis, right after my dialysis. So the timing becomes a problem. Now, what happens with CRRT? Another big issue. With CRRT, what happens? You're losing the whole dose. I mean, with CRRT, you're losing the bloody whole dose that we have when we come with colistin, because it's dialysable. So what happens is, I'm not giving any more 12 million units, I'm giving 20 million units. I mean, 20 million units, I can't imagine the neurotoxicity that would occur with CRRT. So I don't remember the time that with CRRT I've ever used colistin per se. I don't think something you can do of this nature when it comes to dosing. So the dosing is important, but the way to dose it is very essential.
CRRT and polymyxin B?
Oh, so there is. That's the beauty of polymyxin, no? The beauty of polymyxin is I don't really need to change it. I just take the upper dose and I put it on that.
Okay. Any questions from the audience?
Correct. So it's a very interesting question. So what happens with the brain, and for that matter for any antibiotic in the brain, is that the penetration of any antibiotic is around 12%, 12, 13%. You don't really achieve more than that. And if you really want to figure out how much to dose inside, you need to do something called as an inhibitory quotient. We don't do that. So abroad what happens is they would dose, they would take out the CSF, study the serum levels and put up an inhibitory quotient, and then you dose it, redose it. So what do you do in India? Since we don't have all of these things, how do we do this in India? So you can't use polymyxin because you need to use a combination. Okay, so combination of routes. When I say combination, I'm talking of combination of routes. Polymyxin has not been tested intrathecally as well as colistin. Okay, so the entire bargain would be to give colistin IV plus intrathecal colistin. That's the entire point. So if I have something in the brain, I would want to give a combination of colistin IV, intrathecal in combination. This is something I'd like to do. I would probably not be using polymyxin in such case scenarios because of the fact that I know that penetration is 10% and 12%, and I can't do the combination of IV and intrathecal. So it's not something that I do in these cases. So that's how you do. And if it's renally compromised, the same principle follows that I said. If you have dialysis, you give the second dose right after dialysis. You do the intrathecal right after dialysis. So it's a very messy job to actually do that, because you can't just write an order and go. You have to follow that up, call up the nurse, ask her when she's doing dialysis, and if she's doing the dialysis, what time is she finishing it. If she's finishing it somewhere in the middle and she gives 8 p.m. the dialysis is going on, she gives the second dose, you lost colistin. You got the point. So you have to be so methodical that you start colistin. Okay, now your next dose is at say 8 o'clock. You can't do it 3 times a day. That's completely wrong if you have dialysis. If you have dialysis and you have 3 times a day dosing, you will not achieve steady state at all. Whatever you're giving will come out. So colistin you give in the morning, and say you have the next dose at 8 o'clock. I'll time my dialysis at say 4 o'clock. Okay, so that I start my dialysis at 4, complete at 8, and immediately redose the extra dose at 8:30. So it's a huge problem when it comes to colistin and dosing in renal failure. So unfortunately we don't realize this, and we dose it like the way we want to do it, and we don't really understand what happens inside the body. That's a big issue with colistin, correct?
So basically, the issue with therapeutic failure is mainly with the dosing.
Very high. I mean, that's one of the bad publicity that colistin gets is because of clinical failure, because of the fact that we don't dose it right, and or we are scared to dose it right. It's either we don't dose it right or we are scared to dose it right.
So my next question is about duration of therapy. So what factors determine the optimal duration of polymyxin therapy in critically ill patients? And how do we decide when to stop treatment, especially in the absence of robust clinical response markers?
So this would follow the general clinical rule where it says that in the event that the patient is clinically improving and come off everything, and the procalcitonin levels have come to less than 0.25, if you look at biomarkers, CRP started dropping by more than 60%. So that would be the place where I would try to omit colistin and get off the colistin per se. It's going to be a pure clinical like you do with any cases per se, but it's never going to be short because the patients in which I'm using colistin, I'm using colistin in those patients that are extremely ill. So it will be definitely it will not be short. It is going to be a longer time.
Okay.
Yeah.
De-escalation strategies and stewardship practices. How can antimicrobial stewardship programs effectively integrate polymyxins while minimizing resistance development and toxicity? What are the best strategies for de-escalation once susceptibility data becomes available?
All right. So if I'm using colistin, first dose it right. If you don't dose it right, you will have in therapy resistance pattern. In therapy resistance pattern will come in the moment you don't dose it right. So that's one part of the story. Okay, dosing it right. The second part of the story is, you asked me whether you would de-escalate this quicker. No, I would not take the risk of de-escalating colistin quicker at any given moment because this is those patients who are severely ill. The de-escalation pattern would come only in the event that I've started empirically and then I find an organism that is very, very susceptible with acceptable breakpoints in the Enterobacteriaceae. So I would take the risk of reducing or de-escalating only in the presence of Enterobacteriaceae. I would not even do it for Pseudomonas and Acinetobacter where that's the only go-get drug that I have in my hand. I would not do that. And yes, again, their rapid diagnostics makes a big difference over here. We still don't have a way to figure out very quickly whether the patient is having MCR1, MCR2. That's something that is there. So if the MCR gene which is responsible for colistin is present, I'd probably just stop it and just take it off. That is something. Another thing that will probably help to improve colistin is to never, the resistance patterns, never to use it as monotherapy. So it would definitely make the difference in preventing resistance pattern if you were to use it as a combination therapy because you don't know which kind of resistance pattern will develop. One more important thing is the fact that these MCR genes are mobile genes, they are mobile genes. So these are very, very difficult to treat. And that is why, again, I emphasize the fact that if you have normal creatinine, I think it's better to use polymyxin, not to use colistin if you have normal creatinine. Because if you have normal creatinine, I would need to dose colistin very, very high. And when I look at colistin very, very high at say 14 million and 16 million, the average person would not tolerate that. So it's just too much. Yeah.
But sir, the MCR gene-mediated resistance, the prevalence of that is quite low in our setup, right?
No, I would not put it that way. We don't know, and if you were to test it, and that also if you were to test it on a regular basis, and remember this, what is the real testing when you look at colistin? Most of us are doing the standard microbrod dilution techniques only in the large profit-making hospitals across the country. Okay, and these are a select few in the urban localities. The rest are all academic hospitals where the maximum resistance lies. So if you were to check those, I am certain that it would not be low. The MCR gene would not be low. It would be very, very high. We're not checking. I mean, we look for data, you'll get the data. If you don't look for data, that means there is no data is not the answer.
We don't know the right.
Yes, and I'm certain it's going to be high. So when we're doing this has been, whenever we've been doing standard microbrod dilution, first of all, as I told you, we have the answers only to Pseudomonas and Acinetobacter. We don't even have the answers to Klebsiella. We don't even have the answers to the rest of the organism like E. coli. We don't even have the answers. So that way, we are in a very, very premature phase of our investigations when we are coming to understanding the MCR gene. And the only test that can give you is PCR based. There's nothing else that you can do. And everybody can't afford, what's a PCR? It's 20,000 rupees. I mean, we can't do the PCR on every patient. It's not possible. It's not possible.
So my last question for this session is regarding emerging alternatives. So with the development of newer agents like cefiderocol and beta BLBLIs, how do you foresee the future role of polymyxins in managing carbapenem-resistant infections?
So that's where the entire ballgame lies. I mean, the emergence of newer antibiotics will completely change or disrupt the way colistin is going to be used for certain. For certain. Now, already we are seeing the fact that any infection that comes in, and any infection comes in febrile neutropenia, let it be bloodstream infections, let it be any of these infections, empirically, we are no longer using colistin per se. We are now at this moment using high dose ceftazidime-avibactam because practically it's covering every system. It covers the brain, it covers bloodstream infections, it covers catheter-directed infections, it covers urinary tract infections. So we are in the situation where almost everything, if you want to cover empirically, it is ceftazidime-avibactam plus a combination of aztreonam because we do have a higher proportion of MBL, especially when it looks at E. coli. But if you have a prevalence of Acinetobacter more than 10%, this is not something I would probably go to. The go-to drug would be colistin. So say for example, I have a ventilator-associated pneumonia, and the incidence in my hospital is 11-12%. It's higher than 10%. So my go-get drug in that case would not be ceftazidime-avibactam. I might try a very unusual combination of ceftazidime-avibactam plus a colistin or a polymyxin. A very unusual combination, but that's the way it's going to be.
So any more questions from the audience?
Yeah.
Just one question, sir. You talked about polymyxin B versus colistin. And in that light of that, if we're looking at a carbapenem-resistant Acinetobacter, for the bloodstream infection, I can understand that polymyxin would be a better choice. So what happens if there's a half-fat with a carbapenem-resistant Acinetobacter?
Okay, so classically the hospital-acquired pneumonias and the ventilator-associated pneumonias, for that matter, any pneumonia, the amount of antibiotic penetration into the epithelial lining fluid in murine models, in mouse models, has shown that it doesn't really penetrate, and in vivo also it doesn't. That's in vivo, isn't it? In vivo, it's not really working that well. So if you look at colistin penetration into the lung and look at the studies that are there in vivo, you would say I would not use it for a HAP or a VAP, provided I have alternatives that do quite well. So if I have an alternative that is doing well, for example, the ceftazidime-avibactam aztreonam combination. For Acinetobacter, no. So for Acinetobacter, I'm still waiting for sulbactam, durlobactam. I think that would be the blockbuster molecule. If it comes by, it's going to be sulbactam, durlobactam. But at this given moment in our country, if there is Acinetobacter, then it has to be polymyxin. If there is nothing else, and that also not polymyxin on its own, it has to be a combination of polymyxin, roots and drugs. This means to say, I would be dosing polymyxin at its highest therapeutic dose potential that I would be using, 25,000 units per kilogram. And there again, I must tell you, when we are dosing it that way, 25,000 units per kilogram, the maintenance is actually 3/4 the dose. Unfortunately, what happens is, you start at 25,000 units per kilogram and then you go to 10,000 units per kilogram. It is not like that. So it is 25,000 units per kilogram and then you go to somewhere around 17 to 18,000 units per kilogram maintenance per dose. So there again, the education becomes so important, because what happens is a person just gives the dose that is available in the vial. So it's like 15 lakhs and then 7.5 PD. No, it's not like that. So if you're going to give 15, it has to be 10. It has to be 10 and 10. It can't be 15 and 7.5 and 7.5. It can't be that. So that dosing is extremely important. And if I'm going to do that, I need to also add nebulized colistin in these cases, and that also dosed with a vibrating mesh nebulizer at 2 million units twice in a day, ensuring that there is nebulization pre and post. So you have nebulization, then colistin, and then that 2 million units twice a day, plus a sulbactam.
And would you prefer nebulization colistin with IV colistin?
IV and IV as well as nebulization, it has to be there, but at the same time it also needs to the addition of sulbactam. So it's at this moment sulbactam you cannot do without when it comes to either sulbactam or minocycline till the resistance pattern comes by, either sulbactam or minocycline at high doses, you can't do it without that. So you need to have a combination. When I say sulbactam, it's not 2 grams, it's not 4 grams, it's 12 grams. 12. I would probably give 12 grams of sulbactam in such cases because that's what's going to achieve levels for Acinetobacter. That's how it is. And this is not from just experience, it's also from the data that comes along with it. Very strong data that comes in when it looks at Acinetobacter pneumonias in the lung. I think that's the way we should do Acinetobacter. And remember this, Acinetobacter in the lung means a 44% attributable mortality. So you really can't dose it lesser than what it is. It has to be dosed at the high levels. That's how it is, and in these proportions. Yeah.
Just wanted to add that we conducted urine lung infection model study in-house of Polymyxins, and we got really amazing results with the intravenous administration. Although aerosol and inhaler is doing a great work, but the parenteral administration also shows some great efficacy with Polymyxins.
It will. It should ideally, if you dose it right. So the entire point is, it has to be dosed right. Optimization of the dose. The issue is it's not optimized. If you optimize the dose properly, it may do well. It may do what, because the data that has come is not come from multiple studies. It's from one murine thighs model. It's not that there are 20 studies that have shown this. It is just one murine thigh model that has actually showed that the epithelial lining fluid has less amount of colistin as compared to what's happening in the thigh.
I is easy to treat, but the lung infection is something
Difficult, yeah.
very difficult to manage within the ELM. And talking about the resistance of cholesterol, don't you think that the usage of polymyxins are too low as compared to meropenem and let's say any other drug? That's the reason the cholesterol don't have such kind of resistance. But once, like in 2000s, like recently, the cholesterol and polymyxins have started regaining its usage after carbapenem resistance.
Yeah, that's what I'm saying. So
Now if we use it like
it's a beautiful drug. If you ask me, it doesn't get resistant. So if you ask me, it's not going to get resistant, and I'm certain we've been using colistin for like 10, 12 years now, isn't it? 12, more than that, and it's not got resistant. I mean, that is one drug that has stood the test of time compared to so many drugs that have come and gone. In fact, I have a feeling now ceftazidime avibactam is also looking at an exit. Yeah, this is what I'm looking at. It's almost like an exit as of now, because as of now my entire experience says that 1 in 3 patients are getting resistance. So I am ending up with a situation where I'm thinking, oh, this patient is very ill, I can't take any chance. Let me start combination already of polymyxin with ceftazidime avibactam, which is a very unusual combination if you ask me.
like treat MBL infections, which is also a concern.
Yes, MBL is like, it's like there. Every E. coli is MBL. Every E. coli that we're getting is actually an MBL, is what it is looking like. And that's why, we are trying to give combinations of, say, fosfomycin, which somehow works in some MBLs. But I don't know whether, and also we must understand that when we look at, still there, the problem lies with the fact that we need more data to actually get MICs and breakpoints for, these Enterobacteriaceae MBLs. So if you look at Pseudomonas and Acinetobacter, we are clear. But the breakpoints for susceptibility is not very clear when it comes to Enterobacteriaceae. So it's not clear.
Concept is for India, it's very different as compared to like what happens in the US or Europe for CLS and UCAS, because we don't have our own breakpoints. We usually follow
Abroad, but even we don't even have their breakpoints. No. So when you come to,
but
not for all the pathogens, you don't have Klebsiella oxytoca, you don't have Klebsiella pneumonia, we don't have E. coli, we don't have Routella, nothing. We don't have for all of these.
you have for colistin, but not for polymyxin.
Polymyxin.
For UCAS, but for CLS.
CLSA. Polymyxin also needs a lot of data that needs to come in. I mean, colistin, we are actually taking data from colistin and saying this is polymyxin.
Exactly.
But I think polymyxin, I don't know what stops them from actually giving us data on polymyxin, because that will give us more impetus in using polymyxin as a molecule in place of colistin, especially because of the fact that the PK is much better when it comes to polymyxin, much better. So the entire thing as an infectious disease consultant or a critical care consultant is, I want to achieve dose rapidly, reliably, and I should not be scared. So there are 3 things that come into a mind of any intensive care doctor. These 3 things are ably taken in by polymyxin.
So for bloodstream infection, would you prefer polymyxin?
100%, even if it's in the UTI. Even if there is a urinary tract that is having a bloodstream infection,
Okay.
okay, I would still initially start the patient on polymyxin, okay, because of the fact that if there's a bloodstream infection and this patient is very septic, I can't wait for that 4 to 10 hours for actually starting colistin, because you imagine if I have to start colistin and I want to start colistin at 350 and I'm not certain whether it's going to be reliable, it's not rapid, so I give that huge loading dose in the first place, and then I supplement my loading dose in the next 6 odd hours or 8 hours with another dose, and the creatinine goes up because the patient is ill. The nephrologist would probably tell me that it is the colistin that has caused it. That's what's going to happen. You understand? So in these cases, it makes sense to give a good magnanimous dose of polymyxin in these cases, which will achieve effect immediately. But the entire question is that dose has to be very clear. 25,000 units a kilogram. You can't be lower than that. If you go lower than that, the loading dose, it has to be 25,000 units per kilogram, and then the maintenance dose should be, as I said, 3/4 of the loading dose. It can't be the usual dose that it is. It has to be 3/4 of the loading dose. Only then you will achieve a steady state of, say, 2 milligram per liter. Now 2 milligram per liter is the steady state that you need to achieve. You won't achieve 2 milligram. Understand this, that if the patient's kidneys are working well, okay, in colistin, you will need to give higher than what you cannot achieve steady state of 2 milligram per liter with colistin with a normal kidney function. You can't do that. It is not possible. You need to give 16 to 20 million units of colistin. 16 to 20 as a loading dose. You can't achieve colistin steady state concentrations with normal creatinine.
More than 2 microgram per liter is required.
More than you can't achieve. So that to achieve that, you need to give 20 million units of colistin. Who is going to give 20 million units? So that's why polymyxin is something that
It's an active in form.
exactly, it's active. It doesn't really convert. You don't need. It's not a pro drug. It's a active drug that just gets into the system and starts working, which does the job what we wanted to do. Whereas colistin, I don't know whether it's doing the job in the first place because it has to get first converted to CMS, and that also I don't know whether this batch is getting converted or this generic is getting converted or what's happening in this patient. So in short, if colistin is nice to hear, but it doesn't work in the body. It's polymyxin that kind of works in the body the right way. It's only that we don't look into it that minutely, and that's the reason that we start colistin and say it doesn't work. And all this thing about nephrotoxicity and neurotoxicity is there on the background only and only when the patient survives, right? The patient has to survive. So you need to give a high dose of polymyxin. Though I'm alluding to that because of the fact that if you give a high dose of polymyxin, you might think that there may be nephrotoxicity, but the incidence of nephrotoxicity as compared to colistin is so low that you may want to use it at the benefits versus the risk. Yes, it's low. It's lower.
Like how about using like polymyxins in UTI?
Polymyxin, no. So polymyxin B, no. This is something that I would never do. But if say I have a combination of a UTI with a bloodstream infection and don't have ceftazidime avibactam or the newest zidibactam that's coming in, then I would use polymyxin later on. Start with colistin. Start with polymyxin, and then convert to colistin after that. I would probably do something that is not very regular.
So it actually doesn't get clear from the renal.
No, it doesn't. It doesn't.
Like we do not recommend.
No. UTI, no.
But do you like teach the dose based on renal failure?
For polymyxin?
Yeah.
Not at all. So there is the package insert somehow mentions you reduce the dose. If the package insert says you reduce the dose in renal failure, but doesn't make any logical sense because if it's not doing anything to the kidneys, then there is no reason to reduce it. I mean, they say if you reduce it, it will reduce nephrotoxicity. There is no data. It's just a package insert, and that's probably related to regulatory authorities. So I don't think you need to reduce the dose anytime, and this is something that nephrologists very regularly do. They get polymyxin and then they decide let's reduce the dose of polymyxin B. It's a very wrong practice and it's not supposed to be practiced.
So yeah, international consensus guidelines have done some amazing work on polymyxins, but the regulators have come up with the older, like 1960s, 70s thought that we should be using it in UTI, and then it just like goes based on creating care and all this stuff. But that's not something which.
No.
What doctors have done about it?
any more questions from the audience? So in that case, I would like to close the session and I would like to thank Dr. Sanjith Saseedharan